Good afternoon, everybody, and welcome to Grand Rounds. Today, it's my pleasure to introduce Dr. Melissa Wells. Dr. Wells is an internist and a rheumatologist. She did her internal medicine training at the Mayo Clinic and then her rheumatology fellowship at Duke, and has been on the staff at MGMC since June of this year. And she has kindly accepted our invitation today to provide us with a pocket full of Rheumatology Pearls. And please join me in welcoming Dr. Melissa Wells.
Thank you. Thank you. All right. Well, thank you for having me here to talk about the things that I find interesting, which is rheumatology. Always happy to talk about it. It looks like my slides are going. So we'll go ahead and get started. I don't have any financial disclosures associated with this talk. Today we'll be talking on 3 specific things: understanding some of the antibody testing that goes into rheumatology, covering a couple of emergencies in rheumatology, and then some of the preventative measures that we do for our patients with rheumatic diseases. So if you're interested in some further reading, here's some references. So one of the most common questions that I get asked is, which lab test do I order? And I know there's a lot of confusion on this, so hopefully this will help clear up on some of that. So ANA testing, one of the most common things that rheumatology gets consulted on. By itself, this is a non-specific test. It doesn't tell us a lot of information. So getting a good history from the patient and a physical exam is very important into helping us make the diagnosis of autoimmune diseases. The IFA is still considered a gold standard, which we'll go over that in a second. This will provide us information on how positive or the titer for the ANA, as well as patterns, which can provide some important clinical information. The other side of this is a multiplex assay that uses bead antigens instead of a tissue culture to identify the autoantibodies. Unfortunately, this can miss some of the less common autoantibodies. So this is a cartoon of what doing an IFA is. You get the serum dilutions of the sample that are placed onto tissue cultures, the HEP2 cells, gets washed with the IgG ANA antibody, and then washed after that's applied, and then you see that placed there, and then you do another antibody application with the fluorescent tagging and do a wash to remove any excess antibody, and then that's what's visualized underneath the microscope. Most of the time this is by somebody, particularly like a person looking at it, and then these are the different patterns that they can see. So the homogeneous, speckled, peripheral, nucleolar, and centromere. So this is what that looks like, a picture from the ANApatterns.org. This is the homogeneous pattern. This can be associated with further antibody testing, such as the double-stranded DNA, nucleosomes, and histones. This is another pattern that's commonly seen, the nuclear fine speckled. Those can be associated with like the SSA, SSB with Sjogren's, and then the MIP2, TIF1 gamma, TIF1 beta, and the COO, thinking more about like myositis type related autoimmune diseases. And this is another common antibody pattern that we see are the nuclear dense fine speckled. You might have seen on some of the lab tests that you get back the DFS70 or may be associated with DFS70. This specific pattern is less associated with autoimmune disease, and I'll show you some of that data here in a moment. Several studies have been done to see what the positivity rate is within healthy populations. And when using something like an ELISA or multi-bead assay, sometimes that can have a positivity rate of 25% within healthy populations. But then using the IFA, that rate is 15%. So you're capturing more people who have a positive ANA, but who do not have an autoimmune disease with something like an ELISA or a multiplex. The IFA is a little bit more specific. Also, the good news as well, most people who have positive ANAs don't further develop autoimmune diseases. There are some other conditions to keep in mind when ordering an ANA that can lead to positive ANAs. Autoimmune liver disease, thyroid disease, pulmonary hypertension, chronic infections. So we'll often see antibody production in patients who have chronic infections, multiple sclerosis, and then malignancy. And sometimes with malignancies, we'll see patterns that don't typically fit with autoimmune diseases, such as like lupus or rheumatoid arthritis. So this was a study that was performed a few years ago, but they were looking at different ANA patterns and titers to see and comparing people who were healthy versus patients with rheumatic diseases, and seeing what titers kind of break out who's more likely to have an autoimmune disease. If you look over here, that patterns start at 1 to 80 and go up to 1 to 5120. Our lab usually doesn't go up that high. It usually stops at the 12, right around in this area, the 1 to 2560. But as the titer becomes more strongly positive, you have less healthy individuals who have a positive ANA, which is the reverse for patients with rheumatic diseases. And then that was for all patterns. But if we look at those patterns that I showed you the pictures for, the nuclear fine speckled pattern, even at 1 to 640, there were 5 healthy individuals who had the positive ANA. But again, the number dramatically drops as the titer becomes more strongly positive, while patients with rheumatic diseases become more strongly positive. And then that other pattern that I showed you, the dense fine speckled pattern, was found only in the healthy individuals. And even then, some of them had some strongly positive ANA levels. So let's run through a couple of cases. And I want you to think about what tests would you order. So let's say you're seeing a 66-year-old female with dry eyes, dry mouth, and she's got salivary gland enlargement. So with this, think about Sjogren's syndrome. So think about getting an ANA, SSA, SSB. Next, you're seeing a 33-year-old man. He's got symmetric joint pain in the MCPs, wrists, ankles, and his toes, MTPs. This is worse in the morning. He's got stiffness for an hour or more. What are the tests that you're thinking about ordering for this patient? So we're thinking something along the lines of rheumatoid arthritis. So we're going to want to be checking a rheumatoid factor and a CCP to see if that is positive. Now let's say you're also seeing a 33-year-old male, but instead of having peripheral joint involvement, this is low back pain, morning stiffness for a couple of hours, waking up at night, and it's responding to nonsteroidal anti-inflammatories. So with this patient, we're thinking more along the lines of ankylosing spondylitis, and with back pain, we're not necessarily thinking an ANA is going to be useful in this setting. So getting something like an HLA-B27 can be important. Now let's say this is an older gentleman with low back pain in his 50s. This is worse with activity, but still responds to nonsteroidals. So this type of patient isn't fitting with the autoimmune types. This is probably more either mechanical or degenerative in nature. You wouldn't need to order an ANA with something like this. Next, let's say you're seeing a younger woman, 26 years old, joint pain, facial rash. She's got some blood and protein in her urine. What are the tests that you're thinking about ordering? So with this, we're thinking, could this be lupus? So getting an ANA, double-stranded DNA, Smith, RNP, SSA, SSB can become important, especially if she were to decide to become pregnant, as well as antiphospholipid antibodies. Now, I know this can be really confusing, so I think it's really important to have tools to help out. And Dr. Mathu Maheshwaranathan, who's a faculty member at Duke, he puts together these little one-pagers that is what he calls them, room one-pagers, that help nicely summarize the antibody testing and with the condition, and then summarizing the symptoms that go with that. So if you're ever confused about what test you should order, I mean, obviously I'm here to help out, but this can certainly help jumpstart some of the things that we just talked about. All right, now what is a rheumatological emergency? Now, there's not a huge amount of emergencies in rheumatology. We do a lot of managing of our patients in the outpatient setting, but there are some important things to think about. I'm not going to cover all the emergencies in rheumatology, but I was going to go over 2 cases. So case number 1. 43-year-old man presents with an unremarkable past medical history. He's had 6 months of progressive dyspnea, pleuritic chest pain, and intermittent hemoptysis. And he's had an acute worsening of his symptoms and presents to the emergency room. Review of symptoms is positive for decreased appetite, fatigue, and a 25-pound weight loss. But he's not having any fevers, chills, or night sweats. The only medication he is taking is a recently prescribed inhaler for the dyspnea. For his social history, he works at a feather dye factory, he uses alcohol occasionally, and he recently quit smoking. He had about a 10-pack-year history of smoking. No recent sick contacts or travel history. He doesn't have any family history of bleeding disorders or cancers. So examining him, he's tachycardic, tachypneic, but afebrile, he's normotensive, and satting about 91% on room air. You auscultate bilateral crackles and wheezes on exam. He's got hepatomegaly, but no lymphadenopathy. And these are his initial labs. He's got a white count that's elevated at 15,000. He's a little bit anemic with a hemoglobin of 10. His platelets are 59. Prolonged bleeding times, APTT and PT. His creatinine's a little bit elevated. Liver function is unremarkable. So he's admitted. He gets some IV fluids, started on antibiotics for presumed infection and nebulizer treatments. He gets transfused for the anemia and the thrombocytopenia. Undergoes BAL, which shows mild diffuse erythema and hemorrhage. This is sent off for infectious etiologies, all of which have been negative. But unfortunately, his chest x-ray continues to show a worsening alveolar opacities. Echo shows moderate mitral valve stenosis, severe tricuspid regurg with severe pulmonary hypertension with a pressure of 74 millimeters mercury. CT of the chest shows extensive alveolar consolidation. And so far, cultures are negative to date. So we're thinking rheumatologic, so we go ahead and order some labs. ANA is 1 to 40, so based off of our previous information, that's not too strongly positive. I'm not too worried about that. Normal complement levels. When we see people who have lung and kidney involvement, we're always thinking about things like vasculitis, including ANCA-associated vasculitis, and as well as things like good pastures. But unfortunately, his ANCA testing and glomerular basement membrane antibody is negative. So his initial PT and APPT were prolonged, so we got some further anticoagulopathy studies. Fibrinogen is elevated fibrinogen degradation products. D-dimer is up. This factor VIII activity, if you look at the dilution, the percent changes with dilution suggestive of inhibitor. So lupus anticoagulant is the most common type of inhibitor, so prompts some further testing. Lupus anticoagulant was positive, and anticardiolipin antibody IgM is strongly positive at 96. Platelets unfortunately continue to fall, gets treated with transfusion, suffers general tonic-clonic seizures, treated with anti-epileptics. Head CT shows moderate to large acute infarction involving the left parietal occipital cortex, gets started on cyclophosphamide and plasmapheresis. Unfortunately expires 18 days after admission. So I know we just went over all of this, but I hope you've been thinking about what the diagnosis is. So this patient had catastrophic antiphospholipid syndrome. So before we could get into the catastrophic side, I thought it would be important to review the criteria for antiphospholipid syndrome. There are two sets of criteria with this, the clinical criteria and the laboratory criteria. To meet the diagnosis for antiphospholipid syndrome, you need something from both. So the clinical side, that's going to be your thrombosis, so having blood clots, PEs, splenic infarcts, things like that. Oftentimes, antiphospholipid is seen in people who have become pregnant, and so pregnant morbidity goes along with this. Things that meet this criteria are unexplained deaths in normal fetuses over 10 weeks of gestation, premature births with normal morphology of the neonate before 34 weeks because of preeclampsia, eclampsia, or placental insufficiency, or 3 or more consecutive pregnancy losses before 10 weeks of gestation. And then with the labs, to make the diagnosis, these need to be confirmed on 2 separate occasions, separated by 12 weeks. So with the anticardiolipin antibodies, either the IgG or IgM, and the beta-2 glycoprotein antibodies, either the IgG or IgM, both of those need to be above 40. So oftentimes, even though the lab will read it out as above, I think it's 13 or 14 on the lab that we have to 40, that'd be an indeterminate lab. It's not until you get above 40 that we start to call that strongly positive. The patient in the case had a positive antibody of 96, and then lupus anticoagulant. So catastrophic antiphospholipid syndrome is taking this a step further. This is not common. About 1% of patients with antiphospholipid syndrome might experience this complication. But unfortunately, it has a high morbidity of 1 in 3 patients will die. Treatment involves anticoagulation, high dose of steroids, plasmapheresis, IVIG, cyclophosphamide, rituximab, to try and stop that process of the blood clotting. Common systems that are involved with catastrophic antiphospholipid syndrome include renal and pulmonary and CNS, as this patient had, but some of the other areas as well can be involved. These are the criteria to meet for either definitive or probable catastrophic antiphospholipid syndrome. The patient in the case had 3 or more organs involvement, happened in a short period of time, but he did not have the separate lab criteria because unfortunately he expired quickly with his presentation. All right, moving on to case number 2. So this is a 63-year-old woman with a past medical history of GERD. She's got new onset of pain, swelling in her hands, as well as a faint rash on her inner thighs, forearms, and Raynaud's symptoms. Initial workup reveals a positive ANA of 1 to 640, that's speckled, positive SSA, but negative for these other markers. This was seen by derm, had a biopsy. The biopsy of the inner thigh showed neutrophilic urticaria, but the biopsy of the forearm showed morphia profunda. Got started on methotrexate, but common side effect, nausea and vomiting, abdominal pain, and was stopped. So then got put on prednisone 60 milligrams a day. 1 month after starting the prednisone, she presented to the emergency room with severe abdominal pain, nausea, vomiting, jaundice, decreased appetite, and an uncontrolled weight loss of 20 pounds with fevers and chills. She's tachycardic, lethargic, looking pale with scleral icterus. She's got weakness in her bilateral upper and lower extremities and a diffuse abdominal pain on exam. And the following slide are her labs. So these are her labs prior to admission. And then at admission, her creatinine had gone from normal to 2.7 BU, and it also increased to 53. White count, hemoglobin remained normal, but her platelet levels had dropped significantly from 307 to 19. Total bilirubin and direct bilirubin had also increased. Total went up from 1 to 5.2 and direct from 0.2 to 1.1. Transaminases were normal, and during admission, her LDH got checked and was above 1,000, and haptoglobin was less than 6. So nephrology and hematology were consulted. Due to the presentation, there was concern for TTP. She got started on plasmapheresis. Unfortunately, her renal function worsened. Creatinine continued to drop to 3.7, or increased to 3.7. So there was concern for atypical TTP because of an elevated Adams 13. Patient continued to be confused, weak, icteric with joint pain, especially in the hands. So this is where rheumatology got consulted. The exam rheumatology found sclerodactyly, extensive skin thickening, contractions of the hand, telangiectasias on the face, periungual erythema, capillary dilatations on capillaroscopy, and calcinosis. So repeat antibody testing because we like our lab tests. ANA is still positive, but not quite as strong on the titer. The remaining of labs remain negative. Complements are normal. Chest CT shows NSIP and small effusions. So her kidney is biopsied. And the kidney biopsy showed onion skin proliferation with the walls of the infrarenal capillaries and arterioles, fibrinoid necrosis, and glomerular shrinkage. So going through all of this, I hope you've been thinking about the diagnosis. This is scleroderma renal crisis. So about 2 to 15% of patients with diffuse sclerosis will develop scleroderma renal crisis. It's more likely to happen in the first 5 years of diagnosis. Risk factors include steroid use, cyclosporin, and a positive RNA polymerase. So the patient in this case was on steroids before she presented to the hospital. It was a high dose at 60, but there are studies to suggest that even lower doses can be attributed as well. The patient in the case did not have a positive RNA polymerase 3. The mainstay of treatment is ACE inhibitors. 40 to 66% may recover renal function, but the median time to recovery is 1 year. So these are the labs after admission. So she got put on an ACE inhibitor. Creatinine did improve. This is about 4 to 6 months afterwards. Platelet count returned to normal. Total bilirubin, direct bilirubin also returned to normal. LDH and the haptoglobin was not rechecked. So thinking about scleroderma, one of the earliest signs of it is Raynaud's syndrome. So in this picture, you can see the white and blue discoloration. Typically, there's a very well-demarcated line where this color change occurs, and this is because the smaller vessels in the fingers are starting to constrict, and you're losing the blood flow. If the fingers remain cold, they can turn blue and then red with rewarming. Typically, to make the diagnosis of Raynaud's, it's 2 out of the 3 color changes are needed. Puffy fingers can also start to occur in scleroderma, and the skin is starting to thicken. Sometimes this can be confused with some of the other rheumatic conditions, such as something like rheumatoid arthritis or dactylitis from a spondyloarthropathy. But the skin is going to feel thickened and tight on exam. And then this is towards the end of the condition, you start to get sclerodactyly, where the skin is not as puffy as before. The fingertips start to kind of come to a point. Sometimes you can have a little bit of rounding as well. And in this patient, they have contractures that are preventing them from laying their hands out flat. This is looking at the causes of death of patients with scleroderma going back to the 70s to the early 2000s. Previously, renal crisis was one of the leading causes of death in our scleroderma patients. But then right around this time, we started to get into the ACE inhibitors, and we see significant improvement in survival of these patients. But then, of course, that leads to the development of other complications of this condition that lead to death in our patients, such as pulmonary hypertension as well as pulmonary fibrosis. So oftentimes in our patients, we're doing pulmonary function tests and echocardiograms to look for early signs of these developing conditions and complications. So leading into complications in our rheumatic patients, cardiovascular disease is very common in our patients with rheumatic conditions. Rheumatoid arthritis, gout, psoriasis, psoriatic arthritis, ankylosing spondylitis, and lupus have all been associated with an increased risk of cardiovascular events and death. Interesting, in our rheumatoid arthritis patients, there's a lupus lipid paradox, meaning that sometimes if the rheumatoid arthritis is very active, the LDH and total cholesterols may be lower, but the risk of cardiovascular events is still high. In lupus patients, global activity scores such as the Selena-SLEDAI to monitor for disease activity, low complement 3 levels, and lupus anticoagulation positivity are at increased risk for cardiovascular disease. If we break down this further, this is looking specifically at our rheumatoid arthritis and gout patients, which sometimes they can have overlaps in these conditions. Things that are thought to contribute to this risk include the inflammation from different cytokines as well as netosis, traditional risk factors, smoking. A lot of our rheumatoid patients have been smokers, hypertension, and elevated uric acid levels has been associated with cardiovascular risk. This leads to endothelial dysfunction and oxidative stress, and then you develop vasoconstriction, prothrombotic states, elevated LDH, and atherosclerosis. Medications such as NSAIDs and steroids are frequently used in these conditions, which have risk factors for development of cardiovascular risk. This is a study that looked at inflammatory arthritis, but unfortunately there wasn't enough psoriatic arthritis patients and spondyloarthropathy patients to be included in the review. But they looked specifically at the rheumatoid arthritis patients and found that TNF inhibitors did decrease the risk of cardiovascular events, as well as methotrexate also favored improvement of cardiovascular events, favored decreasing cardiovascular events, while nonsteroidal anti-inflammatories increase the risk of cardiovascular events, as well as steroids increase the risk in cardiovascular events in our patients. So we're still trying to wrap our heads around how to best manage this, but I think it's important to note that there's an increased risk associated in these patients, so being mindful of them when we're seeing them in clinic. Screening for hypertension and hyperlipidemia is important, even though sometimes early in the disease course, you can see lower LDH and cholesterol levels. We just warrant rechecking in the future to make sure that they're not going up. Lifestyle modifications, counseling on smoking cessation, weight loss, always important. Minimizing steroid use and nonsteroidals whenever possible. However, it's hard when these patients are in pain. We want to make sure that they're mobile and active to be able to do things, but counseling them on risk factors can be important. And then we often try to treat our patients to remission or low disease activity. So working on advancing therapy if they're still having disease activity, moving towards medications such as biologics to try to help decrease the risk of cardiovascular events in rheumatoid arthritis patients. And then in lupus, there have been studies to show that use of antimalarials, hydroxychloroquine, have decreased the risk of cardiovascular events in our lupus patients. So we always strongly encourage our patients to continue their antimalarials unless there's a strong indication for them not to do that. The European League for Against Rheumatism, or EULAR, recommends using a risk modification calculated at 1.5. So if you get your cardiovascular risk factors and it doesn't account for something like rheumatoid arthritis, the current recommendation is multiplying that times 1.5 to account for the higher risk of cardiovascular disease. They're still trying to work out things for like lupus and other conditions, but still in the works for that. Moving on to reproductive health. This is a very important area of rheumatology. Oftentimes people are like, oh, you only see older people, which is not true. We see all ages in rheumatology. And this is very important to our younger patients. So the American College of Rheumatology, or ACR, strongly recommends that patients with rheumatic disease enter pregnancy with quiescent or low disease activity. So I'm asking my patients often and early about this, if they're of that age where they could become pregnant. And then antibody status is very important in these patients. So do they have antiphospholipid antibodies, positive SSA or positive SSB? So this was from a fellows clinic, just a snapshot in time, looking at patients who were on high-risk medications that could cause birth defects, such as like methotrexate, mycophenolate, cyclophosphamide, and whether or not they were on contraception. Unfortunately, in this study, 23% of those women were not on effective methods of contraception. And then there was even a high number within the study who hadn't even been asked if they were on contraception. So when thinking about contraception choices, going back to our antibodies, the antiphospholipid antibody status becomes very important in these patients because if they are positive for antiphospholipid antibodies, we want to try to avoid the estrogen-based products as that could increase their risk of blood clots. But then they also, and this is from the American College of Rheumatology, break it out further for lupus patients, either in low disease activity or moderate high disease activity, on which medications. The progesterone-based medications are preferred for contraception protection. And then important for something like mycophenolate, which has been associated with birth defects, to require either an IUD or 2 forms of contraception. SSA and SSB carry special risks in patients who might become pregnant. It's associated with neonatal lupus. 10% of those patients might have a baby with a rash. 20% of the children, the newborns might have transient cytopenias, 30% with mild transient transaminases, but the one that we're really concerned about is complete heart block, which occurs about 2%, and it's increased with subsequent pregnancies. So if a woman has had a previous child with a heart block, then her risk dramatically increases with subsequent pregnancies. However, there was an exciting study that came out not that long ago that showed that hydroxychloroquine was extremely effective at preventing recurrent complete heart block, and it decreased that rate by 50%. So now the American College of Rheumatology is conditionally recommending that all women who are positive for SSA and or SSB antibodies be treated with hydroxychloroquine during pregnancy to prevent this complication. Steroids. So it might seem like we use a lot of steroids in rheumatology, and we do, but we always have to be mindful of the complications of that. So less is more when it comes to steroids. So we're always trying to think of ways to decrease the amount of steroids that we're using. So going back to our cases and thinking about our patients, let's say you're seeing a 65-year-old female who has a new onset of right temporal headache and jaw claudication. She's tender on her right temporal artery, and it's firm. Labs show elevated inflammatory markers with a SED rate of 75 and a CRP of 6.5. So you astutely diagnose giant cell arteritis, start on prednisone 60 milligrams per day, and get a biopsy within 2 weeks of starting the steroids. However, that's a lot of steroids, and patients are older who get giant cell arteritis and are at risk for complications. So this is a study from 2017 in which tocilizumab was used in our patients with giant cell arteritis. Going through these lines, the yellow line is the placebo with a 26-week taper of prednisone. The blue line right here is placebo with a 52-week taper of prednisone. The purple line is tocilizumab every other week, and the green line is tocilizumab every week, tracking out to 52 weeks. This is showing that the amount of that, and this is the patients without flares. So as we go along, they're more likely to have flare-ups. So this is showing that the tocilizumab is decreasing the flare-ups, as well as decreasing the need to steroids. So now we're trying to move towards using more medications such as tocilizumab, which is steroid sparing in our patients, to try to help prevent some of the complications of long-term high-dose steroids, as well as prevent these recurrent flare-ups. Tocilizumab, the dose that's been approved is 162 milligrams every other week. This targets the interleukin-6 cytokine. These patients do need to be pre-screened for hepatitis B, C, and TB. However, one of the biggest things that might limit its use is the increased risk for bowel perforation. This is more likely to occur in patients who have diverticulosis or a history of diverticulitis. The risk is about 1% if they've ever had diverticulosis or diverticulitis, and the risk is decreased to about 0.5% if they've never had that. So unfortunately, sometimes this can be limiting in our elderly patients because they have had a history of diverticulosis or diverticulitis. Moving on to another case, 35-year-old male presents with fevers, pneumonia, respiratory failure, and renal failure. Labs show low complement level 4, marked proteinuria, positive C-ANCA of 1 to 640, and positive PR3. Negative drug screen, cryoglobulins, ANA, and antiglomerular basement membrane. Renal biopsy shows diffuse necrotizing crescent post-immune glomerulonephritis. So diagnosing him with ANCA-associated vasculitis. So new this year, and get started on steroids and rituximab for injection. This is, of course, another condition that has high doses of steroids in use, and new this year was the approval of avacopan to help limit steroid use. So this is from the Advocate trial, in which the participants had ANCA-associated vasculitis, and they could have been on rituximab or cyclophosphamide for induction, and then were on taping doses of prednisone. The avacopan was used at 30 milligrams twice a day, and then the prednisone was tapered from there. This did show a decrease of half of the use of the steroid, which is why it did meet FDA approval. So avacopan, this is a small molecule inhibitor targeting the C5a receptor agonist. So it blocks the C5a at the site of the receptor to prevent neutrophil attraction and activation. So this was the mean dose of the placebo group for prednisone at 3,600 milligrams over the course of treatment, and the avacopan group only had about 1,300 milligrams of prednisone. So in summary, just some take-home points on what we covered today. NA titers and patterns are helpful in the diagnosis and management of autoimmune disease. The history can help you choose the antibody testing. Rheumatology emergencies are rare but have significant patient outcomes. Please don't give your scleroderma patients prednisone. unless there's absolute indication for that. Cardiovascular disease is very common in our patients with rheumatic diseases. Antiphospholipid antibodies can impact contraception choices. Hydroxychloroquine can help out patients who might become potentially pregnant and preventing complications if they're positive for SSA or SSB, and then working on trying to use more steroid-sparing agents in our vasculitis patients. So that is it. You have a question? Okay.
And I'm a dosimetrist in radiation oncology, so not a lot of crossover, but I have rheumatoid arthritis as a diagnosis for me. So my question for you is, how do you feel about a whole foods plant-based diet and being part of the treatment regimen for rheumatoid arthritis?
Okay, so for those who can't hear the question was, how do I feel about whole food plants-based diet with patients with rheumatic conditions such as rheumatoid arthritis? Great question. There's a lot of interest these days in diet and rheumatic conditions. I have had some patients who specifically say I feel better if I avoid food X, and I've heard all sorts of different things. There are potential studies out there suggesting things like the Mediterranean diet might be helpful. I've had some patients try specific things. I don't know if anybody specifically has told me they've tried that diet, but in general, we are recommending leaner proteins, lots of fruits and veggies, kind of the things in general. It's still a budding area of research within the rheumatology world. Well, thank you for everybody who joined online and came in person.